Hello, everybody. My name is Jorge Acevedo, and I'm one of the foot and ankle surgeons here at Southeast Orthopedic Specialists. So what we're going to talk about today is minimally invasive bunion surgery. And any questions you guys might have, thank you for listening. My background, as I said, I'm the chief of foot and ankle here at Southeast Orthopedic Specialists. My background, I did my medical school at University of Florida, then did my orthopedic residency in Atlanta, Georgia, followed by foot and ankle fellowship with 2 Hopkins attendings, but we did most of our work at Union Memorial Hospital. And then I went to Palm Beach, where I practiced for 15 years, and then I've been with Southeast for 7 years. So a little bit of basic anatomy first, just so we're all on the same page. In the foot and ankle, there's 26 bones, 33 joints, 19 muscles and tendons, and 107 ligaments. All of these act in concert to balance the forces of the foot. And then there's 4 major neurologic structures, which we won't get into the details of right now. But so you guys understand how we divide the foot and ankle, basically the forefoot, which is mainly what we're talking about today, is the toes and metatarsals. And then the midfoot is that section in blue, which is those bones that have those weird names like cuneiforms and cuboids and naviculars. And then the hindfoot, which is mainly the talus and the calcaneus, or your heel bone. So what is minimally invasive surgery? Well, basically it's simply using smaller incisions along with some specialized instruments that we'll discuss to accomplish the same goals as we do with the open, larger incisions that we used to do. The goals, of course, are to decrease pain, deformity, and improve the function of the foot. But just as a little bit of background, MIS has been around greater than 30 years. It started even before Isham, which is in the 1980s, which is you see on the slide, then progressed to Europe, where they kind of made it what it is today. And we'll go into a little bit of detail with that rising of the 3rd generation. But the 1st generation techniques were from Isham in the 1980s and 1990s. And again, he adopted the minimal approach with the micro motorized bone cutters, which I'll show you later. But the problem was there was no fixation, so a lot of failures. The 2nd generation techniques came around, and a lot of us in orthopedics kind of frowned a little bit because even though they had some internal fixation with these wires that you see on that picture to your right, it was still, we felt, lacked stable internal fixation and did not catch on very well. So it wasn't until 2011 when some of the guys in Europe, including these 2 guys that trained me, David Redfern and Joel Vernois, published their techniques. And what they did is they merged these percutaneous techniques with AO fixation principles. And what that means is AO is kind of like the Swiss techniques we as orthopedists learn to fixate fractures. And basically they applied those fixation techniques to fixate, bunions and other minimally invasive procedures that we do. So just to give you an idea of how this has emerged in the United States, I co-chaired a course in Baltimore in 2014 that was all advanced arthroscopy with no MIS surgery. And then in 2015, we had some friends of ours from Europe that asked if they could do a half-day portion of MIS surgery, and we said, okay. And you can see that by 2018, the MIS had kind of taken over, and it had basically, there was 2 days of MIS surgery, 1 day of arthroscopy. So you can see how it's really kind of emerged. And about 5 years ago or more, my friend and I, Dr. Mangone from Asheville, we went over to England, and we were among the first 5 orthopedic surgeons in the United States to come and actually perform these techniques after being trained by Redfern and Vernois. And when we came back, we did simple stuff like, here's a 75-year-old person that had crowding of the toes, difficulty with shoe wear, and we simply did soft tissue releases and sort of little cuts in the phalanx, or the small bones of the foot, in order to correct the toes. And I know this person's doing pretty well because it's one of my partner's mother-in-law. So she's done very well. So another term that you might have heard is a dorsal bunion, which is a little bit different than what we're going to be talking about today. Dorsal bunion is more in the realm of hallux rigidus or arthritis of the big toe. So, you know, I point this out just as a differentiation, but really so that you know that these techniques can be used in arthritis of the big toe, especially when you have the big spurs over the toes that basically limit the shoe wear you can wear and cause significant pain in the joint. And we used to make these bigger open incisions, as you can see here. But now you could, using the same minimally invasive techniques through little 0.5 centimeter incisions, which is kind of the size of a pencil eraser, if you will. And here's an animation of what we do. We make a small incision on the top of the foot. We elevate the soft tissues. And then as you can see there, we put this little burr or micro motorized burr, and that helps eliminate the large spur. And then we remove the fragments of bone, either with irrigation and or these small specialized instruments. This technique can be used not only in the big toe, but in other parts of the foot, such as you see here. You know, there's these large spurs that some patients get with arthritis in the midfoot area. And here's an x-ray of it, and you can see it there. And then once again, through the small 0.5 centimeter incisions, we elevate the soft tissues. You can see the small nature of the incisions that we use. And then the results, and you can see there, the big bump that you saw before is completely gone. And you can see the nice, you know, lack of trauma to the soft tissues. And here's a before and after picture of that same technique. So what most of you came here for today is the minimally invasive bunion correction. So the remainder of this talk will be about that. But before we get into the surgical aspects of it, basically some of the stuff we use to improve the pain and function of people with bunions is splints, spacers, orthotics, and obviously shoe wear modifications. Because really, there's only 2 ways to treat the bunion, as that quote says: change the shape of your foot or change the shape of the shoe. So how do we do this? Well, traditionally, as you see here, we used to make these rather large incisions that, you know, people had to think twice about because it caused significant amount of pain and, you know, and disability. But now you can see with the minimally invasive approach, you can barely see these incisions that are made. And here's a sort of an animated video. We make a small 0.5 centimeter incision, elevate the soft tissues in much the same way as we did for the chilectomy. And we use this motorized burr to make the cut in the metatarsal. Once the cut is made, then there's a specialized pusher, if you will, that can basically displace the head of the metatarsal. It is then secured with these wires that over which cannulated, or that means holes in the middle, drills and screws are placed in order to secure the bone fragments and allow compression of the bone fragments. We can then use the same burr in order to remove any excess bone on the inside of the foot. And then depending on the amount of correction one needs, we can also add an additional minimally invasive osteotomy called an Aiken osteotomy. And again, through a really small incision using this motorized burr, we cut sort of a section in the bone, and then we bring the toe over and pin it, as you see there, in much the same way as you see in the picture. Okay, so in a more diagrammatic fashion, we draw out the basically the margins of the bone. And then we make, again, a little 0.5 centimeter incision. So you can imagine there's a lot less trauma that happens when we're minimizing these incisions. And this is the actual motorized burr that's used in surgery. And that's actually a picture of me performing the procedure. And then here's the cut that's made through the metatarsal bone. Once that cut is made, well, it's made in a very systematic fashion. You cut the dorsal aspect, followed by the inferior aspect of the metatarsal. And that's what those words mean: superior and inferior aspects of the bone. And the cool thing about this is that these burrs have, and let me see if there's a picture of it in the last one. This thing up here is actually an irrigator. So basically, as I'm doing this, little water's being squirted in the area to keep the temperature in the bone to a minimum. Because one of the greatest complications we had when this first started was people were using these burrs without irrigation, and that caused soft tissue trauma. So then we basically apply the fixation, which is these small screws, 2.5 millimeters or 3.5 millimeters. Just to give you an idea, it's maybe 1/4 inch or less on the width of these screws. And this is what the AO principles that we discussed earlier applied to the bunion mean. So what can you expect after this surgery? Well, here's one of my patients preoperatively. You can see the bunion deformity, and that's why we call it a Hallux valgus deformity, because it's the angle that the hallux makes with the metatarsal. And then at 2 weeks, you can see there's still a little bit of bruising or ecchymosis and swelling. And then at 4 weeks, most of the ecchymosis is gone. The incisions are completely healed. And basically, there is still some residual swelling that you can see. Here's a 50-year-old with a moderate bunion deformity. And once again, you can see on the x-ray, both on the clinical picture, you see the big bump. And then this is what it looks like on an x-ray. So basically, it's not that something's grown over your bone, but it's basically a deformity of the phalanx, which is the small bone, and the metatarsal, which is the bigger bone. So you see the metatarsal sticking out there. So what we do is we shift that metatarsal head over, and then we provide fixation along with the Aiken that we talked about. So here's a more severe deformity in a 60-year-old with severe bunion deformity. Second and third crossover is what this is called, so that you got crossover toe deformity. And then in the old days, we made these big incisions here to correct the first, second, and third rays in order to try and bring them over. But today, you can see here's 3 months post-op. You can barely see the incisions, even though they're really small, both in the phalanges as well as the bunion itself. So here's one patient of mine that had MIS on one side and open procedure on the other.
Had open chevron of the last 10 years ago. And how are you doing, Ms. Bassett?
I'm doing really well. Thank you for a speaker today. On the beach, very comfortable. Without being seen on the top, it's
Okay, so that's the first testimonial. And then the next patient is another patient of mine that had an open procedure on one side. And again, a minimally invasive bunion on the right side performed by myself.
MIS bunionectomy. This is the side that recently did. This side was done by some guy in California with a big incision. But I want you guys to hear what Andrea has to say about the difference between.
So recovery has been a lot smoother with my right foot than it was with my left foot. Flexibility has come is way more advanced in my right leg versus my left leg. The big toe moving. It took me a while before I could move my big toe in my left foot. As far as the swelling, there's a huge difference. It was way more swollen on my left foot than it was on my right foot. Post 5 weeks. I've actually started going to the gym and more just physical abilities than I had before. So
I see you saying this. And how long ago was the left one done?
Okay, so I think it's always better to hear it from my patients than from me. So here's another patient of mine, 65-year-old with a more mild bunion deformity and some deviation of the second and third toes. And the reason I put this in here is just to show you that you don't always have to do the full bunionectomy. You could just do the Aiken procedure as was done here in order to basically bring the toes over and create more room in the forefoot and make it more comfortable for shoe wear. A question I often get is, how does MIS bunionectomy compare to Lapiplasty, which is gained a pretty big buzz in the media? And here's what the Lapiplasty looks like. And again, you got these big incisions, so therefore the morbidity to the soft tissues is going to be greater. They use plates, whereas we just use screws, and you can see the small eraser size incisions, which is what leads to a faster recovery with the MIS bunion. And some of my critics who like Lapiplasty may say, well, Dr. Acevedo, that's not really the same as the Lapiplasty. Well, just so you know, and I wasn't going to get too far into it, but you could do a minimally invasive Lapidus, which is really what the Lapiplasty is, and you could do it with the same minimal incision, so that if you had a deformity that required a Lapidus procedure, this can easily be done as demonstrated here. The Aiken is the same Aiken as I showed before. And then here's the Lapidus procedure done with percutaneous screws. And it's just as effective as with plates. So why minimally invasive surgery? Well, obviously there's minimal soft tissue dissection. There's less stiffness and postoperative pain. It minimizes the complication, and obviously the cosmesis is drastically improved. Thank you very much. And I have some more stuff, but I think I want to open it up to questions from our audience today, and I'll do my best to answer them as effectively as possible. So again, always these questions are better answered with more information, but I'll do my best to answer your question as you've posed it. So usually at around 70, you already have some inherent arthritis in the big toe. So the problem with doing a bunion at once you have arthritis is that you run the risk of still having pain with it after you do the bunionectomy. So traditionally, you do more of arthritic procedures than the bunion procedure when there's arthritis involved. So I'd have to see how much arthritis you have in the joint. If I had the guess and I had a crystal ball, I'd say that the bunion is not for you. Now, you bring up a good point, which is if you don't have much pain, I'm probably going to discourage you from getting, because basically you have the bunion surgery to diminish pain and improve the deformity. So if the deformity is not causing you issues with shoe wear, then there's not a huge reason to do the bunionectomy. Absolutely. So the Taylor's bunion, what they're referring to is if you so I'm using my hand as a foot. I should have had a model here. Sorry about that. So is this metatarsal? It's the outside metatarsal. So that's called a Taylor's bunion. When the same idea, there's a bump on this side. And the same minimally invasive approach is actually used quite effectively for a Taylor's bunion. Yes, so bunions are multifactorial. So there is a hereditary component, although shoe wear, obviously can contribute greatly to it. There's also a traumatic etiology for bunions. So there's multiple causes. That's why most of us would say that bunions are multifactorial, but there's definitely a hereditary component. Great question. So it's definitely done with a local anesthetic. But most of the time when patients ask me about just doing twilight, the problem with twilight is that we get a little bit disoriented and we start moving too much. And you certainly don't want to cut on a moving target, especially when you're using such, tiny instruments, and you really don't want the patient moving their foot. So I usually prefer that they're done, and they're usually done with what's called an LMA, so that the tube doesn't go down your throat or damage with potential to damage your vocal cords. So but you are put to sleep, yes. Okay, that's a great question. So basically, you can put weight on it at as early as 2 weeks. Okay, I kind of want you off of it the first 2 weeks, just because I put you in a splint, and I want all the swelling to come down and the soft tissues to kind of heal, so we can take the sutures out at 2 weeks. And then you can start weight bearing as tolerated. I protect patients in a boot merely because the guys who trained me in Europe put you right to a shoe. But I find that people feel so good after this surgery that they've come in sandals at 2 weeks, and that leads to problems with healing. So I strongly encourage patients to wear a boot for the first 6 to 8 weeks after surgery. And basically, once the swelling is down, then you could go to a regular shoe. Again, a lot of this depends on healing, but basically, cardio workouts, you can ride a bike probably at about 6 to 8 weeks. But actual running, I would want you to wait till you have good bony bridging, which is usually about 9 to 10 weeks at the earliest. So after a full recovery, you can wear elevated heels. I'll leave it that way. Can you wear high heels? Yes, but your chance of recurrence is going to go up. So therefore, I would encourage you to basically leave it to, basically a smaller 1 inch to 1.5 inch heel, rather than the stilettos, which may have contributed to your bunion. So that's a great question. And look, minimally invasive surgery is done for more than just bunions. In the interest of time, I did not talk about all these other procedures that we do with minimally invasive surgery. But if you have a callus, for example, in the bottom of your foot, you got to see what's causing the callus. But some of these minimally invasive procedures are definitely applicable. So for example, in the crossover toe deformity that I showed, that patient had calluses under their foot. So you could basically do through small incisions, do some cuts in the metatarsals to elevate those metatarsals and correct the claw toe deformity. So I didn't go into too much detail on that, but absolutely these MIS procedures can be used for this. The screws will last your lifetime. They are made of titanium. So basically, in any bone healing process that you use screws, it's a race between bone healing and the screw breaking. in anything you do. Even when we put plates and screws for a fracture, same type idea. So basically, you know, and greater than 90% of these heal without any complications. So the screws, unless they bother you, don't come out. But I've had a few patients, and I would say in the literature, if you read the literature, the greatest sequelae is what we call it, because it's not really a complication. It's just patients require removal of the screw if it bothers them. And I, you know, knock on wood, I haven't had a lot of those, but in the literature, you see the screw removal rate is up to about 10%. Great question. I'm glad you asked it. So basically, arthroplasty, that term means you're replacing the joint in some way. So you're replacing the joint. In the great toe, arthroplasties don't do too well. In fact, the latest one that came out, which was some of you may remember the gel type implant, I did at least 20 of those, and the outcomes were not as good as the FDA studies. So I don't do those anymore because those aren't, you know, the outcomes. If you're not, the outcomes are not above 80%, and then I'm not interested. But the arthroplasty. The only arthroplasty I do is something called an interposition arthroplasty, which is an arthritis procedure. So arthroplasties are mainly done for arthritic toes, not really for bunions. So something called an interposition arthroplasty, where we basically shave down the metatarsal and we put a graft over the metatarsal head, and that's called an interposition arthroplasty. But that's getting into more of the arthritis procedures for the big toe. Great question. So unfortunately, that the answer to that is at about 8 to 9 weeks. And that's because that's how long it takes for the bony healing to heal enough, such that if you have to, you know, put the brakes on, there's not going to be a delay in the brake time, and you have much less risk of damaging the repair of the bunion. So if the top of your foot, the top of the foot, so if I'm understanding the question correctly, basically if this person that asked the question, if they're talking about the rest of the foot is swollen, what happens with a bunion deformity is that the big toe takes 30% of the load of the foot. So when you have a bunion deformity, the big toe is really not pulling its weight. So that 30% is distributed among the rest of the foot. So what you get is you get what's called stress overload, which can lead to a stress reaction or a stress fracture in the remainder of the metatarsals of the foot. And that could be why you're getting swelling in the other metatarsals, if I understood your question correctly. Absolutely. So I treat a lot of diabetic patients or patients with diabetes, and the number one thing I tell them is just make sure your hemoglobin A1C, which if you're diabetic, you're familiar with it, is 7 or less. I do reconstruction procedures in addition to these bunion procedures in diabetics. Once again, because of the reason you said, because there's less morbidity to the procedure, less soft tissue trauma to the procedure, and consequently less complications. You will not feel the screw at all. So basically, the screw is basically what meant to compress the bone that was cut. And the bone that was cut, once it's healed, the screw's doing nothing. So basically, once again, it's a race between bone healing or the screw breaking. So the screws don't normally break as long as the bone heals. So you will not feel the screw at all. The screw is not flexible. It's a titanium screw, so it's actually pretty rigid. It's actually its rigidity is similar to that of bone, and that's why they make them out of titanium. Yes, the bones mend together, and it's really remarkable. When I first started doing this type of surgery, I couldn't believe that shifting that head over so drastically would actually grow bone the way it does. And I can honestly say that I was humbled when I saw the amazing ability of the human body to heal the way it does. So that's a great question. You know, every patient has a different threshold for pain. I have everything from patients that don't even know they had surgery. They actually did fine with, I actually use an anti-inflammatory called Celebrex. And I tell you, start with the Celebrex, and then if you have any breakthrough pain, then you could use something stronger, and I give you something stronger. But many people can just do well with the Celebrex, and they might have to take the narcotic once or twice within the first 24-hour period. And then usually after the first 24 hours, it's not necessary.